which is cardiovascular disease. So I don't know if I answered your question with all that rambling, but I think Dr. Sharp could probably say it more eloquently than I can.
I feel like I had a similar journey. I will say to you all though, when I entered into physical therapy school, I 100% was going to be a sports physical therapist. That is absolutely what I wanted to do. I was a collegiate athlete. I worked as an athletic trainer at my undergrad, and I was for sure going into sports. That was it. So I wish I had probably paid a little bit more attention in class when we were going through cardiopulm, now knowing where I am. But it was my long-term clinical experience that in acute care that really sold me on acute care, physical therapy. And then from there, as I've already stated, getting into intensive care and all the rationale that Dr. Saccone has mentioned about how big of an impact we can make in that setting. I can't help it because I'm faculty, so I have to like cite literature because it's evidence-based practice. But there was a phenomenal study done several years ago, probably a decade at this point now, but out of Johns Hopkins that showed having a mobility team in the ICU, meaning a physical therapist. They also had a respiratory therapist and a nurse, but it saved the hospital almost $1 million in the course of a year. The impact that we can have from that is huge, but then the impact that we can have on people's lives. There's also research that shows that about 50% of ICU survivors aren't back to their previous level of function or even working 6 months after discharge from ICU. So the impact that has on people's quality of life, is detrimental. So it's just such to me, a high energy, high intensity place to work, high adrenaline, and also really making a huge, huge impact. That's why I like doing it.
Thank you both. And just as a reminder, we want this to be as interactive a conversation between students and Dr. Sharp and Dr. Saccone as possible. So please feel free at any time. If you have a question, go ahead and raise your hand or just throw it in the chat. But the next thing I wanted to know is, why should a student have an interest in cardiopulmonary physical therapy? You guys have kind of touched on this a little bit in your previous answer, but if you had anything else to add, go ahead and add it now. We'll start with Dr. Sharp.
I'm going to give the really, let me preface that sarcasm is like my primary language, but who here doesn't know someone that has a heart and lungs, right? Like no matter what setting you're in, your patients will have hearts and lungs. So to me, it's really foundational to know cardiopulmonary physical therapy and the cardiovascular and pulmonary system from a physiological standpoint, because no matter the setting you're in, you need to recognize signs and symptoms of dysfunction in those. You could, and especially as we move, and again, we're all in different states around the country, so I'm not sure what everyone's direct access legislation is currently, but I know in Georgia we have direct access. And if you are going to be that first provider to someone, you need to be able to screen for hypertension, for example. And you might be that first person to catch that. And that may then need you to refer back to a physician to be able to help your patient exercise safely. So again, you are going to also see people post-operatively. And what if, there's complications post-operatively, like a pulmonary embolism, and that you need to be able to react really quickly to help save that person's life. And that can happen in the outpatient setting. So again, I think some of these foundational aspects of cardiopulm, I can appreciate that not everyone wants to work in an intensive care. I can appreciate that not everyone's going to go to cardiac rehab, but no matter where you are, you're gonna encounter this. Even the neurologic setting, spinal cord injury is a restrictive lung disease, right? Like, so knowing some of those things, you can weave that into your therapeutic treatment. I was rambling, so Dr. Saccone, I thought I'd let you have an opportunity.
I can totally agree, and I want to dovetail on that. My impression is every patient is a cardiopulmonary patient, and I think Dr. Sharp brought that up. The last example of somebody with a spinal cord injury, they don't have an effective cough. They're going to have secretions. We have to facilitate their coughing. Depending on the level of injury, they have some degree of both inspiratory and expiratory muscle weakness. But that one's a pretty obvious one. But okay, so your patient has Parkinson's disease. Parkinson's disease is a cardiopulmonary disease. People don't succumb from Parkinson's disease. They succumb to the cardiovascular debilitation and pulmonary debilitation from lack of activity. And recently, if you saw the clinical practice guideline for Parkinson's disease, the number one intervention is aerobic training. You can make that analogy to any kind of patient. If you treat a patient, you're treating a cardiopulmonary patient, because Dr. Sharp said they all have heart and lungs. And if the heart and lungs aren't working, none of your interventions are going to do any good. All your neuro interventions, all your orthopedic interventions, they are going to work better if your patient has better cardiopulmonary function. That's fact. And, again, because of the debilitation in our society and the lack of cardiovascular and pulmonary fitness, if we can add that component to any other thing we're doing with a patient, they're going to respond better. They're going to get better. As Dr. Sharp said, the quality of life is going to improve. So that's my T-shirt, right? Every patient is a cardiopulmonary patient. Therefore, every physical therapist should be a cardiopulmonary specialist, not in the sense of being APTA certified, but being, as Dr. Sharp said, competent in both diagnosis, evaluation, and interventions that can help that patient. And I rambled too, so I'm going to stop there.
We'll do one more question before we take a brief break for announcements. This question is for Dr. Saccone. Based on the current state and projected future state of the health of Americans, how important do you think cardiopulmonary physical therapy will be in the coming years?
Again, we're not getting better. We're getting worse. High blood pressure is an epidemic, 46% of adults. About half the people in this country have at least one risk factor: increased LDLs, hypertension, smoking, cigarettes. And it's not getting better. The heart failure, and I say this to my students all the time, heart failure is an epidemic. We are seeing the cases rise. As Dr. Sharp mentioned, the economic effects are astounding. We're going to, in the next 8 years, we're going to be spending twice as much to treat heart failure than we will to treat all forms of cancer. I think that we're spending twice as much just to treat heart failure than we will spend. It's $40 billion is what it's extrapolated or estimated to be. 40 billion, that's a B, $1 billion to treat heart failure, as opposed to about 20 billion to treat all forms of cancer. And back to Sophia's question, good question. I think we're treating other things better. We have better treatments for cancer. People are surviving longer. If you survive longer from other problems, your chances of developing cardiovascular and pulmonary problems goes up. And if you're not doing something to prevent that, it goes up exponentially. So is it going to be important? It's important now. It's going to be more importanter. There you go. Within the coming decade.
Thank you. Looks like we actually have time for one more quick question before announcements. So this question is from Caitlin. She says, I was wondering the differences or overlaps between cardiac rehab with a master's in clinical exercise physiology and that of a cardiopulmonary physical therapist. If you are a cardiopulmonary physical therapist, do you mainly work in hospitals, and what would a typical day look like? I'm going to punt that one to Dr. Sharp.
Perfect. So this is what I'll say. I, again, clinically practice in the hospital in intensive care. Does that mean every cardiovascular and pulmonary clinical specialist does that, or cardiovascular and pulmonary PT? No. My colleague that I teach with works in cardiac rehab in the outpatient setting. And she does work with exercise physiologists to the point of the question. The scope of practice may be a little bit different of what things they can do, but there is definitely some overlap. Zofia, was the second part of that, what is a typical day like? I'm trying to make sure I've touched on everything. Thank you. So when I go to the hospital, my day really consists of chart reviewing in the morning, typically with a lot of coffee, because I don't function without coffee. Anybody else in the room have a coffee problem like I do? Yeah, thank you. Thank you. Yes. And my coffee problem started in PT school. But chart reviewing, typically now when I work at the hospital, I'm either on the cardiothoracic surgery floor and cardiothoracic surgery ICU, or our cardiac floor, which is pretty much 90% heart failure. And then also MI, and then some people that have had to stay over for, PCI stenting procedures. And then I also go to our other various ICUs. So depending on the patients I'm seeing that day, some of it may be that I go to rounds with the whole team in the morning. And that would be myself, the physician, any advanced practice providers. So those are nurse practitioners or PAs, the charge nurse, and the respiratory therapist on the unit. And then we do a really brief rounding of every patient in our ICU to identify needs. And at least at my facility where I am, they very much value what it is I bring to the team as I value what they bring to the team. But they don't pretend to know who is appropriate for mobilization. So that's where it's really important for me to have an understanding of what other individuals' responsibilities are, but also a little bit more of the medical side of it. So I have a very good understanding of pharmacology, because that's going to play a role in physical therapy. And if people are on certain types of drips in an ICU, so something that's being infused continuously, I need to know why they're on it, how much of it they're on, and what could happen if I get them up while they're on that. And is it safe to do that? And then also knowing ventilatory settings. If I have somebody that's on mechanical ventilation, understanding what is it that a ventilator does for that patient, and at what settings does it become unsafe and maybe more traumatic for the pulmonary system to get up. But then also, what are the benefits of getting up, right? The more vertical someone is, the better their oxygenation, their ventilation perfusion is going to be. And doing that. So again, I may start with rounds. If I identify anybody that could be ambulating on a ventilator or on ECMO, that's going to be a situation that there's a communication and a scheduling is what we like to do at our facility of, okay, what time can everybody meet at so-and-so's room so we can do this? If that's not the case for that day, then I'm just bopping in and out of rooms and really assessing what I see that day and meeting the patient where they are. Is it that they're still in bed and they need to get out of bed because the bed is a horrible place to be? Bed rest is not a benign intervention by any stretch of the imagination. I will say I'm very fortunate on our cardiothoracic surgery ICU. Pretty much everyone's out of bed at 6 a.m. So, which is fabulous. Others are not, but, and then from there, just trying to get people back to that prior level of function, whether it's somebody that was pretty sedentary at baseline, or just a few weeks ago, I had a collegiate basketball player who had a congenital heart defect who had to come in for surgery to repair that because she kept having syncopal episodes during practice. So again, did a lot higher level intervention with that college athlete than I did maybe with, my grandma who is 95 and had heart block and needed a pacemaker. But again, so just that typical day of seeing patients in the hospital. I like the hospital because I make my own schedule, if you will. You get therapy when I show up. Don't have to wait for patients to come early, come late. So yes. Is that sufficient, Sophia?
I think so. I'm now going to pass the mic off to Tayo for some brief announcements.
Hey, how's everyone doing? I hope you're enjoying the social so far. Just a quick few announcements that we have. So starting with next Sunday, February 27th at 7 p.m. Eastern Time, we have an APTA Live. It's titled Sharing the Profession on Social Media. And that'll be with our Director of Communications, who is also on this call right now, Casey Schlottman. So what's up, Casey? And it'll be also with two physical therapists that are social media influencers. So they'll be both spreading the word about, physical therapy on numerous social media platforms. So that should be an interesting discussion, and we will put the link below for you to learn more about that event. And so for our next announcement that we have, so it's going to be more about CSM. So if you did go, I hope you enjoyed it. It was a lot of fun in San Antonio, although the weather was not so great. So, but there's another opportunity from March 1st to March 31st. It's going to have the on-demand experience for CSM. And so the deadline for that's going to be March 11th. Now, if you did attend CSM in San Antonio, you will get free access to this. And so if you have a chance to check that out, I would definitely recommend it. There'll be over 100 recorded lectures. So definitely something that you could tune in, and it'll be on your own time versus a specific date like CSM in person. And then the last announcement that we have is that there's going to be a following student social next month in March, and that's going to be centered around women's empowerment and mentorship in our profession. So we have a great panel lined up for that. And when we do make more of the announcements, you'll be able to see some of that. So definitely stay tuned for that next student social. Before I head it back over to Sophia, just, quick thing again, we want this to be interactive. So feel free to unmute yourselves. You probably don't want to hear us talking all the time with these two awesome clinicians. And so this is definitely the time for you to be able to ask those questions and sort of have that back and forth discussion. So again, feel free to raise the hand and unmute and start the conversation. I'll head it back to Sophia.
Thank you, Tayo. So we have a question from Carolina. She says, how have you seen the effects of long COVID change the way you practice? And what do you think this looks like 5 to 10 years from now as we learn more about the long-term effects of COVID? I'm going to punt that one to Dr. Sharp as well.
So I honestly, I don't really know what we will see in the coming years. I think we're still learning a lot. Anecdotally, I saw a lot of different sequelae of COVID with the different waves of COVID. Saw that kind of when it first started, was seeing a lot of patients, a lot of respiratory failure, a lot of renal failure. The next wave saw just this pure kind of respiratory failure picture. And then now we're seeing a lot of vascular complications. So again, and that's anecdotally speaking from what I'm seeing. Again, I don't know where we're going to be in a few years. I think this also opens up the door for a lot of outpatient. I think there needs to be more outpatient providers that are comfortable seeing people with this, as you refer to as long COVID. But seeing a lot of people with a lot of fatigue, and that just decreased activity tolerance. Initially, we're seeing also POTS. Are we familiar with POTS yet? Everybody in your educations? Yes, no? Okay, so postural orthostatic tachycardic syndrome. So that can be really, really a significant impairment to people's lives. So what happens for those that on the call that are not familiar with that is in the just very generic sense is that you stand up, you change position, what have you, your blood pressure tanks, your heart rate skyrockets, and a lot of times these people pass out. That is not safe, right? If people are somewhere alone and they might hit their head or something like that. So I think there is a need for you all as you are entering the profession to feel comfortable assessing the cardiovascular and pulmonary system, because I think we are going to see long-term kind of sequelae of COVID. I don't know exactly what it will be like. Dr. Saccone, do you have any opinions on that?
I think you hit it on the head, saying that it seems to vary so much from person to person, and we're still learning. And the most recent evidence came out that the long haulers may have vagal nerve dysfunction, which would explain the POTS. I mean, if the vagus isn't there to balance it out. So is that going to self-resolve? Is there something we can do? Is it a neurological, is it becoming a neurological or an autonomic dysfunction? That all has to be figured out on the job, as we study these people down the road. But again, I completely agree with you. You have to be comfortable taking blood pressures, assessing heart, looking symptomatically at what the patients are doing when you're getting them up on their feet, even if it's months down the road. And even if, again, you're seeing them for some other condition other than a cardiopulmonary primary diagnosis. And we're going to be seeing them for the orthopedic issues and the musculoskeletal issues because of the debilitation, because of the fatigue. So it's all tied together. But I love the idea that, get good at it, get comfortable with it. The more you do it, the more you assess these blood pressure and heart rates and assess vital signs, the more comfortable you're going to be, the better you're going to be. There ends the sermon.
We have a question from Taylor. She says that her CI in acute care says that she does not hold patients for blood pressure, especially if they are on meds for hypertension. She says that if they are asymptomatic, she does not worry about it. And she's asking, are there any blood pressures that would cause you to hold a patient from physical therapy? Granted, we are usually just transferring to the chair. I'm going to punt that question to Dr. Saccone.
You'll see different cutoffs, but I think the most common one, and Dr. Sharp can back me up on this or not, I think it's 200 over 110. If that's a resting blood pressure, it's a phone call. Don't treat until you've at least spoken with the physician. And a lot of times it will be, yes, this is a poorly controlled situation. Monitor the patient very carefully. Make sure your interventions are very gradual as you're increasing intensities. But we do have guidelines. I mean, we do have cutoffs, so be sure you're familiar with them, either generally like the 200 over 110, or specific to your institution or your cohort, your patient cohort. And it does vary a little bit. Somebody that's had a stroke versus somebody that's maybe a non-neurological condition. I don't know if Dr. Sharp wants to add to that.
I would agree, and I'm going to give you the best favorite physical therapy faculty line ever. Let's all get t-shirts. It depends. I'm sure you've all heard it, right? So to that point, yes, I would absolutely agree, especially that diastolic, because remember what happens during diastole. That's when the cardiac is getting perfused. If you have this high diastolic pressure, it's going to put a lot of work on the heart and not let that happen. So again, to me, that is an absolute phone call. I am not initiating therapy at that moment until then maybe they get some sort of pharmacologic agent to try to help bring that down. On the flip side, I do see a lot of folks in intensive care with heart failure and their blood pressures are in a dumpster, right? But again, you need to know the patient population you're working with. So I absolutely ambulated somebody that had a blood pressure of 60 over 40. That sounds pretty low, because it is. But that was a conversation I had with the physician before I even ascertained the possibility of that. this individual was on a pharmaceutical agent, a drip. She was on milrinone, and that was helping her heart function. She was asymptomatic. And the one thing that I specifically look at and would encourage you all to look at is the MAP, the mean arterial pressure. And what that information gives you is, are the organs being perfused? So typically that should be about 65. And so that's what I look for, especially if I'm seeing people that have typically that have lower blood pressures. I started my clinical career in a medical ICU where the vast majority of my patients had sepsis. And that's a form of distributive shock and specifically categorized by hypotension. So again, my big thing is there MAP in an area that tells me that they're getting perfusion? And that's going to Dr. Sacone's point, differ based upon the patient population I'm in and maybe what else is present. So again, it depends. And I think it is important to know those cutoffs. We have all these guidelines in our Practice Act, but symptoms are important, but also patient safety is important.
Tyler, you can go ahead and ask your question next.
So back to the COVID question, I'm actually working with some post-COVID patients in an outpatient pediatric setting right now. Is there any like tests and measures or anything you'd use or recommend to monitor symptoms or to track progress other than we're using Vital 6-minute walk test, but anything else you guys would recommend?
Yeah.
I'm going to be honest, I don't work in pediatrics, so I'm not sure if there's what outcome measures are maybe specific for pediatrics. I love a 6-minute walk test. And I think that's a great test for endurance. And the other thing I feel like, I know like inpatient we've been using is like the short performance physical battery. Anybody familiar with that? It has 3 components to it. One's a balance component. One is a gait speed component. So either a 3 or a 4 meter walk test. And then it encompasses basically the 5 times sit to stand test. So that will give you some information on lower extremity strength. I don't know specifically any kind of clinometric data regarding that outcome tool in the pediatric population. It's just honestly not an area I'm familiar with. Dr. Sacone, do you have any suggestions?
Yeah, and again, if I understand your question, what are you looking for while you're actually working with the patient, Tyler? Yeah, you have an SpO2 meter on during the 6-minute walk test during the interventions, and you're looking for rapid desaturation. Everybody's seen these things. You got to realize that if it's below 90, their oxygen levels in their blood are probably around 60 millimeters of mercury compared to about 100 where we'd like them to be. So those are so valuable to us. So you want to have that. But we get enamored with looking at numbers sometimes too. So watch the patient, look, what is their coloring doing? Are they have the conversation going, or are they responding appropriately? Are their eyes focused? I always tell people, don't just stare at the numbers and the screens and the pulse meter. Watch the patient and use your normal clinical judgment.
Next question is from Caitlin. She says that she's interested in getting her CCS, and she was wondering, do all hospitals hire cardiopulmonary physical therapists, or depending on where we live, would we have to move to certain regions of the country in order to pursue this job? And where do cardiopulmonary physical therapists typically work? And if you find one setting, is it better than the other to work in? I'm going to give that one to Dr. Sharp.
So I'm thrilled to hear that people are interested in the CCS. We are a small but mighty group of people. When I got my CCS, there were only 300 CCS in the entire country. And you'll find these like pockets of where, you know, a lot of us gather, I guess. But I also think that's because probably mentorship, right? So there's a lot of CCS in Atlanta. I know there's a lot in the Boston area. And this is what I'll say, you absolutely can work anywhere in the country, and any hospital facility or outpatient facility would be beyond happy to have you, because it's such a small group right now. We're growing. I think we just had our biggest class, if you will, cohort of individuals that passed the CCS exam this past year. It was near 40. So we're growing, we're absolutely growing. And I think people are seeing the importance of this specialty. And I think it just depends on what you as an individual are interested in. The people that I sit with, for example, on the Academy of Cardiopulmonary board, there are people in outpatient pulmonary rehab, outpatient cardiac rehab, intensive care. It's just what you like. So if you like more of the outpatient environment, you know, maybe those outpatient cardiac and pulmonary rehabs are for you. Less potential bodily fluid, I guess. I see everybody nodding like that's disgusting. But again, I think to that point, you have to look at your self-reflect on what you want out of a clinic experience. Maybe outpatient is more of that typical Monday to Friday, 8 to 5. Acute care offers a wide variety of hours. And I think it also gives you another, if you're somebody that is really interested in academia and maybe becoming faculty at some point in your career, a CCS is a really nice thing to have. Because again, there's just not a lot of us. And if teaching is something you may want to do, that can just help you get your foot in the door there. Did I answer the question?
Can I just add to that too? I mean,
Absolutely.
if you want to be in demand, be a cardiovascular and pulmonary clinical specialist. As Dr. Sharp mentioned, as of last November, there's 378 specialists out of 100,000 APTA members. That's 0.4%. That's extraordinary. Cardiovascular pulmonary specialty was the first specialty. We've got now orthopedics and sports, and it was the first. So right away, you get a sense that this was recognized as being something really important. So if you want to be a specialist, and this is your passion, again, you got to follow your passion in this career, you are going to be in demand. And that's all I'll say. Michael has his hand up. I see, and Tayo has his hand up too. So I don't know if you want to, Sophia, if you want to go to them or not.
I'll hit one more question from the chat and then we'll pass the mic off to Tayo and then Michael afterwards. So this question I got is from Tara and it's for Dr. Saccone. She says, how do you think that the physical therapy profession can improve primary prevention for those at risk for heart disease?
I want you guys, the students, to get a program going called 30 for Dessert, where we get every t-shirt, right? 30 for dessert, where we get everybody out walking for 30 minutes every night instead of eating ice cream. We got to encourage patients. And you know, some people hear the word exercise is a 4-letter word to a lot of people. We've got to encourage people to increase their activity. And we're not asking them to run marathons. 30 minutes, brisk walking most days of the week. If we can get people, and some people can't, they have orthopedic issues. They live in an area where it's not safe to do that. But if you get people out walking 30 minutes, brisk walking, most days of the week, the risks of cardiovascular disease, type 2 diabetes, they again, remarkably improved. We're not talking about very intricate and time-intensive or equipment-intensive interventions. So that's what we got to do. We got to start at grassroots level, ground level, get people moving. And, you know, I always talked about my students about, I'm a huge fan of mall walkers, and getting them out and become social. You get a group to walk with, then it becomes a motivational thing where you're very happy to go out 3 days a week. And you know these people now, and you talk about other things like your grandchildren. So we got to get people going on that. And I think, again, we can be proactive in encouraging increased activity before there's a problem. I don't know if I answered your question, Tara, but that's it.
I love it. 30 for dessert.
For
So
dessert.
next, I'll pass the mic off to Tayo. You can go ahead and unmute.
Yeah, I was just going to ask if if you both could share maybe a favorite or interesting time that you had with a patient that was more cardiopulmonary related.
I have a lot. I think for starters, I think what really hooked me into this was that very first patient I ambulated on a ventilator. And the adrenaline I had doing that was like a high I've never experienced. And it was just this unbelievable feeling, but also to see the joy in that patient's face that that she could do that. And then it became this, like, every day the nursing staff would help her out of bed and she would just wait for me to come. It was like the highlight of her day. And so that was a phenomenal experience. Also, just, I think, being that light in somebody's worst time has made a really big impact on me. Like, we see people in the ICU, this is not a good day for you, you know, and that's my day job, right? So sometimes people come in and they're like, oh, I'm going to work. But that to me is an opportunity to make a difference in someone's day and someone's life. And to see sometimes the patients that come back to just say thank you, and you don't even recognize them. There was one woman, she was postpartum, had a huge hemorrhage during delivery, ended up in our ICU, almost needed to get cannulated for ECMO, but she made it through that first night. And but it was very tenuous, to say the least. And several weeks later, I remember being at the nurses station and this woman all dressed up came in, and I asked her if I could help her find her family or what and she was like, no, I came to see you, and mentioned all these other people and like, thank you. And I literally looked at her and could not place her. And then she showed me a picture on her phone of what she looked like in the ICU bed. And immediately I was like, oh my gosh, you like almost died. And now you drove yourself to the hospital for your follow-up. And then you're coming to say thank you. And so to me, you know, and maybe all of us going to work, it might just be that normal, typical day. And I don't think anything of it, but to her, I mean, we as a team, I mean, saved her life so that she could go back to her husband and her brand new baby. And that was the impact that we made for her.
And next, Michael, you can go ahead and unmute and ask your question.
All right, I kind of have two for you guys. So one, Dr. Sharp, you inspired this question. As I've been going through school, I've very much been focused on orthopedics, outpatient type therapy, and I have a clinical coming up in an outpatient cardiopulmonary rehab center. So what is kind of like what's something you'd say is like a mindset change going from thinking kind of orthopedics to thinking cardiopulmonary? One thing you already mentioned was you kind of be down on medications. I think that was really good. Do you have anything else like that? Either of you guys that kind of you guys are thinking about going from that different setting?
I think to prep for like outpatient cardiac rehab, and I can't speak for every cardiac rehab in the country, but I do know the one that I am familiar with that we have in our healthcare system here. I'd be comfortable with EKGs, and maybe knowing at least the basics of it. You're going to see some wild things on those monitors, right? And we don't expect you to know everything on it. But there's a lot of rhythms that you should be able, in my opinion, to identify. AFib being a huge risk factor for stroke, right? You lose that atrial kick at the end, and that's also so important for somebody to have that stroke volume to be able to perform exercise, right? As just one example, but a little bit of that EKG, brush up on that. And again, if you're on is this a long-term for you, Michael, or is it a short, an itty bitty one?
Like the length of my clinical stay?
Yes.
It's 6 weeks.
6 weeks.
So it's
Okay.
short.
So again, you can probably pick some of that up during the clinical if you, but again, if you can brush up on it, I think that would definitely give you a leg up. And again, all that cardiac pharmacology and what the implications are as a PT in that setting. And I think the biggest thing I have, regardless if you're going into cardiac rehab, inpatient, neuro, whatever, as a student, be a sponge. Have just an open mind about everything, because you literally, as I said, I 100% was going into sports. Okay. I saw myself in Major League Baseball. Like that's where I really wanted to be. But I got into the hospital and was like, these are my people. I love this. And it was something I never, ever, I didn't even know how PTs went into a hospital until I got to school. Had no idea. Absolutely zero. So again, you can do, it's 6 weeks. You can do anything for 6 weeks, right? So again, going into that mindset of what can, and again, if you're into ortho and maybe it won't change your mind, right? And that's fine. But then what can you pull out of that clinical that you could then apply to outpatient orthopedics? What if you see somebody who had their knee replaced, but maybe had an MI a few years ago and had a cabbage, what have you? And what can you pull out of this experience that can maybe make an impact in your orthopedic, place? And maybe it's that, and I don't want to put words in your mouth, Michael. Maybe you want to open up your own practice. Maybe you want to practice somewhere where you are direct access. So again, think about whatever it is you learn here, how can you apply that to what you want to be professionally?
If I could add, Michael, you're bringing a ton of info into that setting from your orthopedic background. Your heart failure patients are orthopedic patients. Heart failure and pulmonary diseases are musculoskeletal diseases. There's a lot of musculoskeletal. You're going to do a lot of strengthening activities. So I'll add to what Dr. Sharp said, ask questions, be confident, ask questions, but you're bringing a lot to the table from your orthopedic background. I'm going to flip it. I said, earlier, all patients are cardiopulmonary patients. All cardiopulmonary patients are basically neuro and orthopedic patients. So this is why, and this came up earlier, what's the difference between what you're going to do versus maybe an exercise scientist or an exercise phys person? You're bringing so much of everything you do. You're going to have to make sure range of motion is adequate to do the activities. You're going to have to make sure there's no muscle imbalances. This is when you shine as treating the whole person. You're not treating the heart and lungs, you're treating the human. So be confident. If you don't understand what's going on, ask questions, but you're coming in with so much more than you know right in the door. Good luck.
Did you have a second part, Michael?
I did, and it's a totally unrelated question, but it is a second question. So I am actually a physical therapist assistant student. And so I was going to ask both of you guys if you've had any experiences in the field working with PTAs, and what are qualities or characteristics that you guys as PTs are looking for in that PTA to PT team communication wise, or really anything. Just if you could share your experiences with that.
Dr. Sharp, you want to go?
Yes, I absolutely can. I will say at one, I've worked at a few different hospitals, and one hospital where I was, we did have a handful of PTAs. And I will say for the most part, I personally did not work with them because they were not coming into the intensive care unit, although they had an interest, and I actually fought for them to be able to come in and do treatment. But it was not my decision. But I will say that those PTAs that I worked with were mainly on the orthopedic floor. So working with people after joint replacements, spinal surgeries. And then we also had PTAs working on our neurologic floor with individuals that had suffered strokes. To your point about communication, I think this is something for every single person on this call, and to note is that we need to be able to have open communication with each other. And yes, there's going to be maybe some handoff between a PT and a PTA, but I also as a PT might be handing off to another PT. And to have that just open communication, there's a lot of great communication tools that one can use if you are bringing up maybe difficult conversations about a patient. So there's like, I love SBAR, that the nurses are phenomenal. Are we familiar with SBAR, team? No, I see no's. Okay, so SBAR is a really nice, succinct form of communication where you give the situation, the background, your then assessment and recommendations. So this is what you'll see if you see when nurses do handoff with each other, or if there's like, a transport nurse. And it's just a really nice way to kind of wrap things up. I'd even argue that we sort of SBAR sometimes with each other, just about our day-to-day lives. The other thing I was going to bring up, Michael and everybody, is then another term called CUS, C-U-S, which is, oh gosh, totally blanked. It's like, I'm concerned. Totally blanked on it. But you state your concern that you're having. So maybe as a PTA, you've gone in and now you're working with maybe somebody that had a knee replacement. And now you're noticing that they have like more swelling. They are having more redness. Maybe the limb is hot, right? And now you're concerned about infection or, something like that. So you can then use this framework of, expressing how that is. And it really puts it in a nice format to make it come across maybe not so confrontational if you're worried about something like that. But yeah, I would highly recommend looking into sort of those tools for communication.
Looks like we have time.
Thank you, Felicia. I had just a total, I was like, I know S is safety, could not remember U for my life. Uncomfortable. Thank you.
It looks like we have time for one more question. This is a quick one. Christiana wants to know if you are aware of any certified courses for cardiopulmonary that student physical therapy assistants can do.
Can you repeat the question?
Are either of you aware of any certified courses that that student physical therapy assistants can do in the cardiopulmonary field?
As a student, I would finish first and then look at a continuing ed. Let's one step at a time. That's always my philosophy. I don't know, Dr. Sharp, you want to?
Right, I would agree. Like, y'all have a lot going on just being students. Okay, it's a lot. I would just absorb what you're going through in school, and then right when you graduate, if you need additional guidance, then yes, there are a bunch of things out there you can pay for to help your understanding of certain topic areas. But yeah, I would wait, and I would wait.
I think once you find your passion, then you're going to really seek those opportunities out to really follow it more. So let's look at everything that's on the table first, and then I think you'll get a much more a clear view of which avenue you want to pursue, and you're going to really follow it.
Right. There are great resources on the APTA learning space. Some, I know, like when COVID hit, there was a collaboration between many of the academies to create the PACER project. And that was free and offered a lot of great information around that. And I mean, after you graduate, I think if this is your passion, then there's a ton of courses I think everybody should take if you've determined this, especially if in intensive care. There's some really phenomenal workshops that can help you.
You can see in the chat, there's definitely opportunities, but
Oh,
I
wow.
always look at
Yeah.
PT school and PTA school is like, again, a smorgasbord. Like, taste everything on it first, and then you'll start to we'll go back for seconds.
And then last quick question before we move on to breakout rooms. So when Jimmy McKay found out that we were going to be having this student social and that Dr. Saccone would be on it, he tweeted at us to make sure that we ask you about your band. So Dr. Saccone, would you mind elaborating about that?
Yeah, well, we're all PTs. We all work together, and we'll be playing again downtown Ithaca on April Fool's Day. So if you're in the area, drop in. Yeah, that all started in a very weird way, where one of our faculty said, I can sing. So we made her sing, and she really could sing. So we got together and started working on some songs, and it just took off from there. We're supposed to do a small desk concert from the local station on end of April. So I'll send you the link that at least you can listen to it. So that could be fun.
That's awesome. Does your band have a name?
It's called Desert Stones, because when we first started practicing, I used to buy these cookies called Desert Stone cookies. My favorite cookie. It's a great cardiopulmonary topic. And bring them to practice every day. So we got named after, we're the only band around that's named after a cookie.
I love it.
Yeah, it's fun.
And then it looks like we're out of time for questions, but Dr. Sharp and Dr. Saccone, would you mind sharing your contact information? We did get quite a few more questions in the chat, but I don't think we'll have time to get to all of them,
Yeah, turn the lights on.
any of them before we go into the break rooms. So if you wouldn't mind, please share your contact information so that students can reach out to you.
I placed my email in the chat, so more than happy to answer any questions via email. Reach out.
If I spelled things right, it's just my last name. It's simple. My last name at ithaca.edu.
Thank you both so much for joining us and for all your wisdom. And thank you to all the students who joined us tonight. Stay tuned for more information about the March Student Social coming next month. And at this time, we're going to move into our breakout room. So stick around if you want to stay for that.
Thank you
Thank
for
you.
having us.
Yeah, this was a pleasure. Really was fun. Good luck, everybody. Good luck in all your studies, and hopefully we'll see you out in the clinic.
Can't wait to see all the big changes you all will make.
Yep.
Hey, have a good night.
Have a good night. Stay warm.